by the cytokine storm induced by the alloreactivity, GCSF by itself, which we use quite frequently, calcineurin inhibitors, but also, of course, all the release of LPS and dumps. So then you have a huge cascade, which at the end would lead to endothelial damage and apoptosis. And of course, if it is occurring at the level of an organ, well, you will end up with an organ damage. However, you need also to be aware that not all endothelium or endothelial cells are created equal. We have endothelial cells everywhere, but they are different when it comes to the liver, to the lung, or elsewhere. And actually, depending on the type of the endothelial cell that will be insulted or injured, you will see actually different complications. If we are talking about a systemic capillary damage, so no specific organ being involved, actually, this is what we call, for instance, one complication is the capillary leak syndrome. And the most senior colleagues in the room may remember that in the early 90s, when GCSF was approved, actually there was like a warning about capillary leak syndrome and GCSF. Obviously today, that's not really a big matter of concern. But it has been, I would say, back into the podium recently with the approval of new families of drugs like tagraxafosp for BPDCN. We have also the famous engraftment syndrome, which is the most puzzling thing we see in transplant because, they engraft, they got a little bit of fever, red skin, a little bit of weight gain, and then you give a little bit of steroids and everything goes well. So for me, it's a very, very enigmatic syndrome. TMA will be discussed by Professor Duarte, and he will explain to you the new scoring, classifications, and therapy. Now, if we have a more localized capillary damage in a given organ, so limited to one organ, liver, this is VOD SOS. Lung, we can have diffuse alveolar hemorrhage. Although we rarely speak about it because the diagnosis is usually made post-mortem, it has been seen on autopsies, we can have actually VOD of the lung. It exists. And I personally believe that there are some severe cases of liver VOD where we have simultaneously lung VOD. When we're talking about the brain, this is the Press syndrome and thrombotic also microangiopathy. So where do we put actually these endothelial complications? I really like this paper from now 8 years ago in BBMT, where they have looked to more than 1,000, I think 1,500 patients, and they were actually looking into some causes of death. When you are transplanted and you die, what is the reason to die? Well, relapse is the number one, and I think this is established that the number one cause of failure of an allotransplant is actually disease recurrence. You have GVHD, infections, organ failure, even secondary malignancies. But there is this group of 16%, which classified as other. I mean, other 16%, that's a lot. So what is this 16%? So you can see it in the paper. Don't worry, you don't need to read this. This is it. So when you look carefully, what is the other causes? You can see that number one is VOD, followed by other, I would say, rare complications, which some of them are actually also includes the endothelium. And by the way, you have papers from the mid-2000s showing that the endothelium is also involved in the initiation of acute GVHD, although we don't speak a lot about it these days when it comes to the pathophysiology of GVHD. So you would appreciate that at the end of the day, why people put other, because usually patients die with multi-organ failure when it comes to these complications. And multi-organ failure is sort of a mixed bag of very heterogeneous many things. And let me give you some evidence why this is important. So 3 or 4 years ago, we undertook a project with one of my students within the acute leukemia working party, looking into 200 patients, 202 actually, who died of multi-organ failure. So in the registry, people ticked cause of death, multi-organ failure. And then we wanted to know, actually, before having multi-organ failure, there is a trigger. Something started. You don't usually suddenly start with your kidney, lung, liver, everything dysfunctioning. And to make a long story short, we went back to the files, we dig deeper and deeper, we could find that actually out of these so-called multi-organ failures, 1/3, which is a lot, 1/3, 35%, are actually VOD related. The initiating factor was VOD SOS in the liver. And actually, only 31% of them were previously diagnosed because things went so quickly. It's a very rapid dynamic process. Things went so quickly where we had multi-organ damage in different organs at the same time and quickly, and patient unfortunately died. And actually, when you look to the criteria for diagnosing VOD, and here, please don't misunderstand me, it's not an issue of that the physician wasn't able to do it. The problem was that these were really complex cases because 34% actually could be diagnosed according to the Seattle criteria, modified Seattle criteria. 59% according to the EBMT criteria. 7% actually were very heterogeneous. So the diagnosis was very complicated, and to make things even more complicated, actually 40% of them had also acute GVHD at the same time. So you would imagine, yesterday we had a presentation from Professor Sika showing us a case of a patient who had VOD, CRS, and TMA at the same time. So then you would imagine that at the end of the day, unfortunately, when this patient died, well, it is multi-organ failure. But then what was the trigger? So it is very important to have in mind that probably we are underdiagnosing these endothelial complications. And this is why we thought recently when it comes to VOD, and Professor Duarte will speak about TMA, these are collaborative efforts going at the same time in the same direction. We're trying to refine the way to diagnose, but also most importantly, to early identify these complications. Because if you really want to be therapeutically impactful, you need to intervene early. Because multi-organ failure is not a goal per se. And if you try to treat or resuscitate someone with multi-organ failure, the likelihood of success is going to be poor. It doesn't mean we should not do it, but actually, probably it's going to be too late. And this is exactly what we did recently with more than 35 colleagues, an international group from the EBMT, where we thought to rethink a little bit the way we envision things. Looking, for instance, into risk factors of VOD. Usually when you look to the literature, including some of my own papers, it's a shopping list. But actually, having a shopping list of risk factors may not be extremely useful for the investigators. So what we thought is maybe we should a little bit categorize the shopping list. There are things that are unmodifiable. These are the things, the most expensive things on your shopping list. You can't buy them. You can't do anything about them. The age of the patient, if the patient is 70, you can't do anything about it. But there are things that are modifiable. These are things within reach. You can work on them. And see, for instance, you can adjust your conditioning regimen. You can choose whatever drug or GVHD prophylaxis you want to use. You can choose the way you would like to deliver alimentation to the patient, enteral versus parenteral, etc. So this is one way of trying to facilitate the work of the investigators. The other thing, in order to avoid the shopping list, we try to tidy it up, but also to have a sort of a risk, a relative risk. What are the most important ones? Because in a huge list, maybe 3 or 4 factors are the most important. And this is what you can see in bold here. I will not go into all the details, but for instance, identifying the use of gemtuzumab or inotuzumab is crucial as a risk factor. A pre-existing liver disease is an important parameter. Identifying the dose of or adjusting the dose of treosulfan is important because depending on the other risk factor, if you want to use a fully myeloablative conditioning, then you need to be careful if there are other risk factors. This is where if you have other risk factors, you may wish to decrease the dose of treosulfan, busulfan, or even TBI. So these are really practical parameters. Diagnostic. Originally, the global thought was that to do any diagnosis, actually in medicine for all of us, the patient is complaining of symptoms. A list of symptoms together give you a syndrome, and a list of syndrome give you a disease. But that means you are in the perfect ideal world. And rarely the patient would tick all the boxes. That is the story we are facing with VOD, because at presentation, the patient are not fulfilling all the criteria in general. In addition, there has been some progress, especially when it comes to imaging, and namely the measurement of liver stiffness. And that wasn't available 10 years ago when we discussed this topic. This is why we ended up in a consensus which is actually quite common in hematology, in fungal infections, in fever of unknown origin, and in many situations where maybe we should distinguish 3 scenarios. One scenario is a proven scenario. Okay, you did a biopsy and you have a pathology. This is like, the universal truth. You can't do anything about it. But this is very rare because we rarely do these kind of biopsies. Then you have a scenario in the middle, which is a common one, clinical. Okay, the patient is fulfilling all the criteria, so easy. But then the most difficult part is that when the patient is not fulfilling all the criteria, and this is where we introduce the concept of probability. So this is the probable VOD. And by definition, probability doesn't mean 100%. You may get it wrong, you may get it right. We initiate an antifungal therapy, but at some point we can stop it because we then say it's not a fungal infection. We initiate a probabilistic antibiotic, but then we can stop it, etc. And that is, I think, a very important advance. And moreover, if you are able to do your elastography to measure your liver stiffness, then you are having an additional very powerful parameter which has been validated now in a randomized trial done in Italy. So in the Elasto VOD study that has been led by the Bologna group. So putting all this together, you can see we believe that it will be probably, hopefully, easier to identify early these complex cases. And once you identified or suspected the cases, the idea is to grade the severity. And it is again about the most severe cases. These are the cases you would like to avoid. You would like to intervene very early. And this is why we thought that we needed to move away from the concept of multi-organ failure that I was criticizing originally, maybe to the concept of multi-organ damage. So to try to immediately detect and identify which organ damage started. And this is why we modified the criteria. Again, it is published, open access. I will not go into the details. But the most objective part to identify the multi-organ damage, how can I define a multi-organ damage? For us, for instance, hematologists, when our creatinine, the creatinine of the patient starts worsening, I'm a little bit worried. Sometimes I call the nephrologist and they say, oh, no, it's okay. You can wait. And on the other hand, we are called for, 50,000 platelets. The GP, the physician is worried, and we say, 50,000, fine, it can wait. So this is why we had to rely on objective criteria of an organ damage. And we realized that actually the intensive care colleagues have identified the criteria to define in a very refined manner the multi-organ damage through the SOFA criteria published in 1996. And again, I'm not going into the details, but clearly all of this is available. So you can appreciate that by assessing accurately the risk factors, by having an early diagnosis, and then evaluating the severity, you will be able to have an early diagnosis, early intervention, and there is a huge amount of data suggesting that if you intervene early, within 24 or 48 hours, when you suspect the diagnosis, actually the outcome of the patient will not be dismal. It will be improved. And this is where we believe the field should go. And this is exactly the philosophy, I think, that is now being followed also in the field of TMA. So thank you very much for your attention, and I'm happy to take questions.
Thank you, Professor Monti, for a very important practice lecture. And any questions?
Maybe after the TMA talk, because these are on the team. Yeah. So it's my pleasure to introduce Professor Duarte from Madrid, who is really a great contributor of the TMA field. He has contributed to the most recent criteria and some of the registration trials of some anti-complement in this field. Thank you, Rafa.
Thank you, Mohammed. So, worst thing of creating big expectations is that then, you're sort of like humbled when you come up here. Anyway, I'm going to try over the next 20 minutes, thank you, Mohammed, to share with you what I think is this current state of the art. And normally when you say state of the art in management, we are talking about, or we think we're talking about drugs and new options. But I think that we have to also think about how we do a wholesome management of patients. And that includes diagnosis, and that includes risk stratification. From this perspective, I think this is my disclosures, and it's true. I'm an investigator for some of the trials from Alexion, and I'm an advisor on also using drugs in development for Omeros and for Sobi. I'm also mentioned some defibrotide, and I also want to put there my links to Just Pharmaceuticals. I'll go very quick on this, and the first couple of slides are just to highlight something that Mohammed has explained very clearly. None of these are isolated diseases. We might give them a tag name, we might call them something in a book, but those are syndromes that happen in response to the same endothelial injury that drives all these syndromes. So I think that is something that we need to keep in mind. And then when they present themselves in patients, They don't happen as in isolation, like this patient having a TMA. No, the patient's having GVHD, and some of them are having veno-occlusive disease, and some of them are having also drug injuries of their kidneys, and some of them, there's many of these things, and that makes the management particularly challenging. These are the key endothelial dysfunction syndromes early after transplant. And then when you look at how we try to identify these syndromes, you can see here that many of them share lots of symptoms. Their clinical manifestations overlap. So perhaps TA-TMA is one of the endothelial dysfunction syndromes that is more challenging in the sense that there's a number of features of microangiopathy that are very clear, but this eventually can affect all the organs that Mohammed has just mentioned. And you can have not only jaundice, and you can have renal dysfunction, you can have lung infiltrates, and you can have diarrhea and bloody diarrhea, and you can have neurological dysfunction, you can evolve to multi-organ dysfunction. So it's one of these syndromes in which all of these organs can be affected, which is not to say that necessarily any damage, any injury in one of those organs is always going to be caused by TMA. And many times we also need to consider that some of these complications can coexist. We are trained to try and make differential diagnosis of syndromes to identify the one diagnosis, but sometimes patients do have more than one thing. GVHD, acute GVHD, and TA-TMA are clearly one of the combinations that we can have. Not only that, TA-TMA is one of several conditions that can lead to microangiopathy. And the treatments are not the same for all of these patients. I think that's also an important concept to keep in mind. Manifestations, clinical features, and I'll just go after the introduction with a little bit more of time here. We have manifestations of microangiopathic hemolytic anemia, and these are the blocks from our EBMT handbook. Anemia, thrombocytopenia, increased transfusion requirements, high LDH, schistocytes with all the difficulties that they have to validate among different centers, and EBMT has been one of the key studies, or this is one of the key studies to try and show the difficulty in assessing schistocytes, decreased haptoglobin, manifestations of organ damage, kidney, lungs, GI tract, CNS, polycerositis, all these as potential manifestations of TA-TMA, and then recommendations for a systematic screening that many of us or some of us do that may vary from pediatric patients to adult patients in the way that we monitor some of these things. For instance, regular systematic screening of proteinuria, that's one of the things that might change. Schistocytes in peripheral blood monitoring, all these may vary, but these are the current recommendations that we have. There's something additional to add to this, in particular for endothelial dysfunction syndromes and for TMA, and it's that these clinical features can spread across time. This data, and this is a figure from Sonata Jodel from Cincinnati, who's looked at this into a lot of detail, in particular in pediatric patients, and who's shown us that these criteria can come and go at different time points, and that the diagnosis and the recognition of this complication needs to incorporate at least a time frame. That could be 10 days, that could be 2 weeks. Normally it's becoming a more form of consensus. It should be around 2 weeks, which is what she originally proposed from children, what's also being recognized in the new criteria. So with all this information, knowing about the syndromic presentation of endothelial dysfunction syndromes, knowing about TMA being one of the ones that can actually affect more different organs, and knowing that we have both blood hemolytic microangiopathy features and also organ damaging features, we should have it pretty easy. What's the current landscape? Are we good? Are we missing cases? Mohammed was just telling us about how are we doing with the new criteria to try and avoid missing cases of VOD in some of these patients. So are we missing cases of TMA? And the reality is, what we look at the information we have, it is not particularly encouraging. when we look at diagnostic rates and incidence, it goes anything from 4 to 70%. In children, from 3 to 40%. Clearly, for the most part, we don't know what we're talking about, because there's not such huge difference in patient characteristics that can justify differences in diagnosis in many of these studies, from something less than 5-10% rare complications to 2/3 of the patients. It is true that, like with most of these diseases, we don't have specific biomarkers and diagnostic biomarkers that can help us be very precise. Many of the alterations that we see can happen in many different conditions. That's a limitation. Then biopsies are rarely obtained because of the inherent risk of biopsies. And then I'll share with you some of the elements about how useful in some of these cases, particularly for TMA, biopsies could be. And then we end up having an association of this TMA with morbidity and with mortality, with the limitation that we end up having a formal full diagnosis only when we get to the point that the presentation is so severe that things are just gonna go wrong. So clearly we need to improve from here. There have been multiple criteria. You got there a list of the majority of criteria we've used for the past years from different groups and with different people leading on this. And you can see that there's a relative link between some of the criteria. Elevated LDH and schistocytes have been traditionally always there. This is just a sign. Those are signs of microangiopathy. It is also true that we know now that it's very difficult to calculate those. And what do you mean? 2 or greater number of schistocytes per high-power field. That doesn't mean the same thing at King's. If Tony Pagluca looks at it, that Puerta de Hierro, if I look at it, even if I look at it in 3 different times and 3 different weeks, it might not be the same, and we know that now. Elevated LDH is perhaps a more reliable one, but there's a lot of things that can cause elevated LDH. And then the rest of the criteria, as you can see, have been managed in different ways in different criteria a long time. I'll highlight perhaps here the Sonato-Judel criteria, which are pediatric and which are already nearly a decade old, and of course, and perhaps approach to diagnosing children always has differences with adult patients, and we believe overall that even the incidence might be higher. But she moved in a direction of 2 things: trying on the one hand incorporating as many of these features as possible, and at the same time a lot of that work of the work in her group has gone with studying complement, and in particular soluble C5b9 as a trigger, as a biomarker to lead to diagnosis and also probably severity of these patients. Even though the reality is that, as you know, it's not that soluble C5b9 is not very readily available for most of us. This is pretty much limited to just a very few centers in the States. Dana-Farber, Fred Hatch, they all send their samples to Cincinnati to be done because it's just not feasible to do this elsewhere. And you all know that this is also challenging because complement continues to be activated in the tube when you send it. So it needs to be done in particular conditions, and time is important, and how all this is done is important. So this is what we had. And then this, just past year, and this was presented at last TBMT, the new criteria, we had a new harmonization effort, a new attempt to bring together all these different criteria and create something that we could all be guided by and apply consistently across the globe. This is the harmonizing criteria. I mean, this is good in the sense that anything against harmony. You know, these are the harmony criteria. Of course, this cannot be anything. Anything that brings harmony to the field is always going to be positive. But I think that we need to look into a little more detail into what is the final product that we got from here, because what we've really done with this criteria, what's really come out of Schottler is the first author, young physician, pediatric, Atlanta, also with a particular approach from the pediatric management of these patients from this field. And what we've pretty much done here is simply translating what were the classical Jodell's criteria to be applied throughout pediatric and adults. And for some of these criteria, there's been small modifications. For instance, the number of schistocytes, since we couldn't agree to, since the people couldn't agree, then what they've done in the manuscript just say schistocytes present or absent, something rather general. And with the whole idea that if you have 4 or more of these criteria a couple of times within a 2-week time frame, then you have a formal diagnosis. And it's a formal diagnosis, yes, no. It's not a formal diagnosis, which is something that in very severe complications, I think is something that we are accustomed to do and that helps managing patients. It's not, as Mohammed was saying before, an attempt to do, we have like a proven or formal diagnosis, then we got a probable diagnosis in a situation of certain uncertainty in the diagnosis of these patients. So this is what we have now. Clearly, this has an advantage. With this criteria, we're gonna make sure that every TMA, severe TMA case we've got out there, we're gonna be able to identify with this criteria. The problem that we see is that if we apply to this criteria, not only to the TMA cases, but to every single transplant recipient in the first 100 days after transplant, there might be many others that never had a TMA, that never developed a TMA, and then are going to tick 4 of those boxes. In particular, some of those boxes are laboratory results that can be done only in particular settings and that show sort of like a complement activation that can happen in many other settings. We've included here as well the C5b9 positivity, and we don't have yet in adults, and it's being validated by Sonata and her team in pediatric, we don't have real cutoff points that we can use as a real sign of severity coming from the level of C5b9. Because this was so broad, the team did something reasonable, which was at least standardize risk and say, okay, so this is all that it might be a TMA. And then we call it TMA, but we know that really what we need to treat here are high-risk TMA. And those are the factors that have been suggested as high-risk TMA. Then the LDH, instead of just over the limit, twice over the limit. The same value for diagnosis is value for high risk for proteinuria. Any TMA organ dysfunction, except the very mild acute kidney injury, even though there's other reasons, potential and differential diagnosis for organ dysfunction in these patients. Any elevated soluble C5b9 is part of a severe presentation as well. And then concurrent GVHD or concurrent systemic infection. So a large majority of these patients with this diagnostic criteria are going to be, according to this criteria, high-risk TA-TMA. So this is very recent. So we are starting to see, and we see a first publication, this came out in August, attempting to do external validation, saying, you know, how does this apply to my real patients? I'm going to get all my lot of patients, I'm going to apply this criteria. And this was Shengli Ma, who's from Seattle, from Sangeeta Hingorani's team in Seattle, who's now in Texas, did on a group of pediatrics still closer to what the original Jodell's criteria were developing in children, transplant recipients, and they pretty much applied this retrospectively along with their own criteria and said, how do they work in our transplant recipients? And this is what they saw. If you apply it in yellow is the curve of the cumulative incidence of TMA with the standard criteria in these children. That was 12.7, 13%. And that's fairly reasonable, what many centers have produced. However, if you apply the new harmonization ASTCT criteria, High-risk patients would be 28%, that red curve. And if you include them all, standard risk patients would be over a third. And I wonder whether we really think we do have over a third bona fide TMA cases in our hands. Nearly 30% of severe TMA cases in our hands. I definitely don't have that many, fortunately. It may vary, but I think that we need to still look at these criteria. And they look into something else, which was also survival. What happens to these patients? And then all these patients that had a concurrent diagnosis with both criteria, this is the patients that really had issues. And these are the patients that they treated with eculizumab and with other things. These are the patients that fulfill both original criteria and the new harmonization criteria. However, if you look in green, those are all the patients that never met the original criteria and, however, would have been TMA based on the new harmonization criteria. Those patients were never treated with anything because they didn't know they had TMA, and they actually survived. 100% of them survived. Those are not severe TMA cases. So I'm sure we're going to carry on having more studies like that. This is our own study with Sergio Giralt, with Sumi Vasu, with Vincent Ho, with Gabi Rondon, with many people with an interest in the field, looking into improving TMA criteria that we presented at last year's CBMT, looking into a natural history study with a classification of what we thought, similar to Mohammad's view, that we need to, at least in very severe complications with uncertainty about diagnosis, give a proven versus probable option. There needs to be something that tells us this is a bona fide disease for sure, and this is something that is probable. That's a level of probability, and see how those behave. And then we look at this into, you can see this is nearly 4,000 patients, 300 pediatrics, 3,400 from 12 centers all over the world, Germany, Spain, and the US. And all these possible that met, less number of criteria, those were very many, and they didn't match well between centers. It's only when you get to the proven or the definite or to get to the probable that you actually have some level of good reproducibility among centers. And the last point on diagnosis, of course, renal biopsies are very important. But when you look, this is a study from Montreal, Roy et al., that retrospectively looked during a decade, all cases that had renal biopsies for renal dysfunction, 17 of them. And out of the 17 cases, for different indications, none of whom had had a formal diagnosis of TMA, you can see that they found localized TMA in the kidney without signs of systemic TMA in 10 out of 17, so a vast majority. We need to take into consideration biopsies, but even patients that are positive in biopsies, we need to continue to look into systemic features because we might have local renal presentations that do not necessarily give you the full phenotype and clinical phenotype of systemic biopsies, of systemic TMA. So I'll finish just with a couple of mentions on the therapies. There are no currently approved therapies. There's a number of supportive care treatments with different potential benefits, but also limitations. There's a lot of discussion about whether or not we should discontinue immunosuppressive drugs. There's a limited role for plasma exchange, obviously. Everything that is management, fluid disbalance, hypertension, all that clearly contributes. Taking other renal injury drugs is all important. But there's not anything that has been approved. There's a few things that I wanted to mention here. First, there's a potential role for endothelial therapy with the fibrotype. This is a study one of the people from my team, Maria Martinez, published already a few years ago in 28, 4 years ago, 5 years ago now, on a single center series of 17 cases of TA-TMA treated with the fibrotype based on the availability of the drug, but also the endothelial dysfunction as a base for these complications, with rates of response of 2/3, 65% in a median of 14 days. So that's experience that we gained. There's a few other studies, one of them from EBNT for the Pediatric Disease Working Party, with about the same numbers of patients. There's experience out there. And then, of course, what we're all looking for is the new anti-complement agents in development. I'm not going to be able to give you a lot of information on this because it's true that I'm directly actually involved. I'm an investigator for the ravulizumab trial that is ongoing. I mean, eculizumab is what's being used everywhere. My concern about eculizumab and a full C5 blockade in our patients is that in our PNH patients, it's very well tolerated. There's nothing that major that happens. Our patients are so immunosuppressed that if you do a full blockade of all the complement, there's going to be probably infective complications more often than in your PNH patients. And I think that's something that needs to be looked at into these trials. Pegcetacoplan is a C3 inhibitor. That's probably where the field is moving in the PNH world as well. There's oral formulate drugs and CA3. This is CA3. Pegcetacoplan is my last slide. And still, this is ongoing. And then narsoplimab is an anti-lectin pathway MAPS2 inhibition that is also a new drug, and it's in the process of discussion for approval. So I won't go into more detail in there. So the state-of-the-art in management of TMA still requires new drugs to be developed. And we're still in early phases for some of these drugs and in running trials in some others. I think that nevertheless, we have new tools, and the same way that Mohammed was in the lead for the new tools that help us manage well VOD, I think that we need to continue to revise the new criteria, including this harmonization criteria for TMA, in a way that we're sure we don't miss patients, but we're also sure that the patients that we take as TMA are not going to be a third of our patients, many of whom survive perfectly well without any specific treatment. Without anything else, we'll take the questions. Thank you.
Any questions?
I have a question, in fact, for both of you. Thank you for your two very nice talks. Transplantation is a permanently moving field with introduction of new things. And notably, over the last 15 years, we are treated older and older patients, and we are treating more patients with an haplo donor. As these two parameters impact the field of TMA or other kind of endothelial problems, and if yes, why? Because if the answer is yes, we may find a reason to develop some kind of treatment, the first thing. And the second thing, it may also allow us to perhaps have a better diagnosis taking into account these two parameters.
Thank you, Didier. Thank you, Professor Blaise. That is a key question. We had a morning session focused on VOD yesterday, and this is one of the questions that came out. We've all jumped into the post-transplant cycle because it made feasible what we couldn't do before that. And it changes around the world, and there's places where in Asia it's very common that the doses that they're using are lower. Mohammed and other groups here in France are reconciling lower doses of cyclophosphamide with ATG, but the reality is that we don't know a lot. In all these initial trials, you get hard endpoints. You get survival or not, relapse or not, event-free survival, but we don't have granularity of what is that happens with all these other complications. We're starting to learn about early cardiac acute events, and Remy Dulery and other people from France and from other places have given us shed some light into that, but I don't think we have a lot of information on what's happening with this. With the gut feeling, because we do continue to have patients with some of these complications, it does have an impact. The level of fluid overload, the level and cardiac failure may have something to do with it, but the level of fluid overload and renal dysfunction that we had with these patients with high dose post-transplant cycle, I think that it's one of the things that we need to look at initially retrospectively, like it's been looked at for acute cardiac, and I think that is something that might help us at least identify risk. It's true that the risk factors of mismatched donors, all those are already there in our risk factors found for some of these, but specifically the post-transplant cycle and the world of TMA, it is something that we need to look at in more detail. Absolutely.
Yeah. I have a similar question in the last one about the TMA in CAR T cells. So we have the CRS, we have the monocyte activation, we have the HLH, we have also similar scenario in CAR T cells, So any data of TMA in CAR T-cell patients?
Not that. I mean, we have been we have an active CAR T-cell program, but in Spain, all that there were very few centers started a couple of years ago, and the rest of it started like last year. So we don't have hands-on experience to give you our an answer on that.
Cytokine profile in patients with TMA was done. Various cytokine level to see if it's up or when there is endothelial damage?
There's many studies. Mohammed was mentioning that Enrique is perhaps the leading figure on endothelial damage with all this. We are not at the point even that we know whether calcineurin inhibitors, which is one of the triggers, and that triggers endothelial damage and can be measured with biomarkers, whether removing calcineurin inhibitors is required or not. And many groups advocate that it should not be removed, and we need to intervene earlier with drugs directed towards the complement. So I don't think we don't have a biomarker that is yet validated.
Yes, a quick question also for both of you. Most of the data are coming from Western countries. Have we any idea of what is going on in China, for example? Is there the same incidence? Is there the same severity?
Mm-hmm.
For TMA in China, but I can answer for VOD. And for VOD, it looks like that the incidence in general is lower, but at the same time, it's difficult to compare because they have a more aggressive policy in decreasing the dose of drugs, especially when it comes to the conditioning regimen. Also, the age of the transplant patient is significantly younger. On the other hand, they have more pre-existing liver diseases, especially because of Hep C and Hep B. So this is why I'm a little bit, I believe there's probably, in contrast to GVHD, for instance, between Japan and Western countries, I don't really believe that there is such a big difference related to the ethnicity.
Mm-hmm. Thank you.
So, okay, we're going to move forward and we will continue with these complications. And now it's my pleasure to welcome